Good afternoon. Welcome to the NF2 and Schwannomatosis clinical care session of the day. We're very excited you're here today to hear some of the greatest updates in NF2 and Schwannomatosis clinical care. Dr. Calamaridis and I will co-chair the session today and really had a number of exciting abstracts to sort through. We're really excited for those that have been selected among the abstracts in these categories to present to you today in platform presentations. But we're going to start with one invited speaker today, Dr. Scott Plotkin, a professor of neurology at Harvard Medical School, is going to give us an update on clinical trials in NF2 and schwannomatosis. So thank you, Scott, for joining us today.
My pleasure, and thank you very much, Dr. Jordan, for the introduction, to the session chairs for the invitation, and also to the meeting chairs for the opportunity to give an update on clinical trials in NF2 and schwannomatosis. I will say that the last session on gene therapy I found to be extremely exciting, and I very much hope that within 5 to 10 years, our communities are implementing these clinical trials into practice. We may not have an approved gene therapy by that point, but I am very hopeful that will be moving forward. And with that, I will, see if I can use the technology. Give me 1 second. There we go. Here are the disclosures about my conflicts of interest, as well as the fact that none of the drugs here that are mentioned are approved for use in NF2. So I include this slide on NF2 not because anyone needs introduction at this point to the features of NF2, but really to emphasize the key finding that patients with NF2 have a range of tumors, including vestibular, non-vestibular schwannomas, meningiomas, spinal ependymomas, and spinal and peripheral schwannomas. And it's this multiplicity of tumor types and multiplicity of tumors which makes NF2 so challenging to treat. And we all know that although these tumors are histologically benign, that clinically they can be very aggressive and cause significant neurological dysfunction. And so here's a list of the trials as I am aware of them for NF2 over the past 10 to 12 years. What I wanted to highlight here is just to show that this list, which includes on the top completed and published studies, as well as on the bottom, either studies that are complete but not published, or studies that are ongoing, that this includes a range of different drugs targeting different molecular proteins and targeting different tumor types. And one thing I'll point here in, trying to get my laser pointer. Okay. Here, that the vast majority of trials to date have targeted vestibular schwannomas, which is a very important manifestation of NF2, but it certainly is not the only one, as I mentioned. And so I'm going to focus talking, as I mentioned, that we're going to hear about later today, results of a study of axitinib for NF2, and so I won't go into that in great detail. And I'm going to focus instead on these ongoing trials here, looking at selumetinib, crizotinib, as well as the Intuit NF2 trial for NF2. So first, just to review the ongoing study, as I mentioned, of selumetinib in patients with NF2-related tumors. The study PI is Trent Hummel from Cincinnati, and you can see him smiling at you right here. This is a study that's built on published data, primarily from Cristina Valles Fernandez's laboratory, showing that NEC signaling pathway is upregulated in NF2 deficient tumors. And they published this series looking at a variety of MEK inhibitors and their ability to inhibit the growth of cell lines as well as tumor models in mice. And this provided the basis for moving ahead with a human clinical trial. You can see the study schema here. This is an innovative study in which patients with NF2 are divided into those who have vestibular schwannomas with hearing loss, that is stratum 1, as well as those patients who have other tumors without hearing loss. You can see here that all patients are ages 3 to 45. They do not require histologic confirmation to participate, but must have measurable disease on MRI. The patients here in stratum 1 are being tested to assess the hearing response rate at 24 weeks to see the benefit of selumetinib, whereas patients in stratum 2 are being treated with a primary goal of determining the radiographic response of NF2 related tumors. So these are strata looking at different aspects of tumor biology. One is the neurologic complication, and number 2 being the size of the tumors. The enrollment to date has been somewhat slow, according to Dr. Hummel. He mentioned that the trial has been open since 2017. There are, as you can see here, the two strata are at different spots. There are 7 spots open prior to the interim analysis for those individuals with vestibular schwannoma and hearing loss. The stratum 2 is progressing nicely with only 3 spots open before the interim analysis. So we hope that that enrollment will continue and that we'll be able to hear those interim results soon. A second study to highlight here is an open label phase 2 clinical trial of crizotinib for children and adults with NF2 and progressive vestibular schwannomas. This is a study that's being run by the Neurofibromatosis Clinical Trials Consortium. The study chair is Dr. Karianis, and the study co-chair is Dr. NF2. And this study is also built on significant preclinical data that comes out of the laboratory of Professor Kissel that showed that crizotinib, through its action not as an ALK inhibitor, but instead as its action as a FAK inhibitor, had benefit or at least signs of activity in both in vitro and in vivo models of NF2. Happily, the drug is already approved for metastatic non-small cell lung cancer, meaning that we can get access to it, as well as meaning that we have significant information about the toxicity of these compounds. The drug also, of course, has a recommended phase 2 dose, as you can see here, and this is being used in the subsequent trial. Here is a schema of that trial showing an initial treatment period after which patients are required to hold drug. However, in a very innovative design that the NF Clinical Trials Consortium has been pushing forward, it allows for retreatment in patients who have progression after discontinuing drug. That gives us very valuable information about the long-term benefit of short-term treatment, as well as a possible re-response, that is shrinkage again, for tumors that grow after treatment. Here you can see the key eligibility. This treats patients as young as 6 years of age who have confirmed NF2 and have progressive tumors. The primary endpoint in this case is tumor shrinkage, similar to stratum 2 of the trial for selumetinib. And I've highlighted this analysis, this statistical plan here. It's a Simon 2-stage design where the first 9 participants are enrolled. We look for efficacy at that point. If there's at least one response, we then move on to a second stage. And my understanding of the enrollment to date is that stage 1 has been fully enrolled, treatment is ongoing, and we again hope to hear about this interim analysis in the coming months to decide whether we move on to the second stage of the trial. Now, I alluded to the fact that one of the challenges of NF2 is that we really don't have the right tools right now for clinical trials in this rare tumor suppressor syndrome. And I alluded again to the challenges of this multiplicity with multiple tumor types and multiple tumors. It's very clear to everyone that the time between trials is too long and that we spend years developing these trials. Also, it becomes challenging to compare results across trials because they may have different inclusion criteria, different ages, and different endpoints. And finally, and importantly, it is challenging to convince our pharmaceutical company partners to invest in this rare disease space. And although we have been able to do that, and we're very grateful for that support, it always remains a challenge. Therefore, we need to think about novel trial designs in the setting of NF2 and other rare conditions. And I want to introduce some people, but just remind others of 2 trial designs that we've incorporated into the Intuit NF2 trial. The first is the concept of a basket trial, and this is a trial design in which the effect of one drug on tumors with the common mutation can be performed at the same time. And the benefit of looking at a drug that has NF2 deficient meningioma, NF2 deficient schwannoma, NF2 deficient ependymoma is that it greatly increases the number of patients who are eligible for clinical trials, which is great. And it also allows us to understand whether drugs are active across a range of histologies with a common genetic pathogenic variant. The second type of novel trial design is a platform trial, and platform trials are randomized phase 2 designs that involve multiple drugs. And that's a way of having patients who have a common eligibility get treated with different drugs, but they have a common response rate and a common infrastructure. So the common eligibility allows us to better compare participants across drugs. The common response rate, again, helps us promote this comparison across treatment arms. And finally, the common infrastructure reduces the time between trials and makes it much easier to study multiple drugs. And so this is what a platform basket trial would look like schematically. You have a master protocol that represents the platform trial, and that master protocol is how we put all these drugs into one study. And then individual drug studies are added by amendment along the way. So you can see here the platform design is you have drug A, drug B, and so forth. The basket design is you're looking the effect on tumor type 1, tumor type 2, and so forth. And so you get this grid where you can look across drugs and across tumor types to see what's active and then move it to the next stage of development. One last thing to mention is that these novel designs can be further enhanced through the use of adaptive trial designs. And it's important to understand that an adaptive trial is one that changes after it starts. It's built to change and to adapt itself to incoming data. And so these adaptations can enhance the efficiency of your trial. For example, if you build up interim analyses that allow you to decide which tumor type is responding better, you can then cone down to the tumor types that are most likely to respond. Or you can look at futility and stop treating participants with a drug if it looks like it's not going to be active. This also promotes the flexibility that I was referring to so that you can more quickly open and close arms that look promising. And finally, one last thing to note is that this concept of perpetual platform trials, that is, it's never designed to be just one drug, 2 drugs, or 3 drugs. You leave it open, and so you can add drugs as you go along and forever, making it quite a valuable resource for our community. With that understanding, I'd like to tell you about the Intuit NF2 trial, which is an attempt to incorporate some of these novel designs into an NF2 specific trial. The rationale of this study is to rapidly and efficiently screen therapies for biological effect, and we're using radiographic response as that effect. And as I mentioned, we're looking across multiple tumor types driven by NF2 loss. This allows us also to look, as I said, within individual tumor types to see which ones are most responsive to these new agents. Here is a schematic design of the trial. You can see there's 2 gray boxes. The top box represents the master trial, where patients with neurofibromatosis 2 who have tumor progression enroll. At that stage, we have common eligibility and common endpoints that promote comparison across drugs. You can see the basket component here with 4 different tumor baskets: vestibular schwannomas, non-vestibular schwannomas, meningiomas, and ependymomas. Patients then get randomized to the different drug sub-studies, and they're treated until a time if their tumor progresses, and if so, they're allowed to rotate back into the master trial where they can then be re-randomized to a new treatment. And we hope that this provides participants with as many options for drug treatment as possible in the most rapid time possible. Here are the Intuit NF2 trial sites and updates, and I want to specifically thank all of the site PIs participating here. The study opened in June of 2020 with one drug, as you'll hear about, called brigatinib. There was very rapid enrollment due to the hard work of everyone and also to our patient community. And you can see here the types of target tumors enrolled include all 4 baskets. And so we hope to have some of that information soon. We are not currently enrolling on the trial as the first stage is complete, as you'll hear about, and we're awaiting analysis to see whether a second stage will open. So the master trial design is as follows. Up to 80 eligible participants with NF2 and progressive tumors get enrolled. As I mentioned, they're allocated at random to drug sub-studies. And then each sub-study will have 40 participants, and I'm going to elaborate on that more. And we hope that this will be open for at least 10 years. Here are some of the primary and secondary objectives. I won't go through this in detail given our time limitation, but to say the primary objective is to assess activity using radiographic response, that is tumor shrinkage, as our primary endpoint. And secondary objectives include safety and tolerability in this patient population. And we have a number of exploratory endpoints, which we hope will allow us to better understand the effect of these new agents on these tumors. I should mention that in addition to studying the target tumor, so let's say vestibular schwannoma, we are monitoring other tumors as well. So we're going to have a lot of data on the effect on not just the target tumor, but also non-target tumors. Here are the inclusion criteria for this trial: a diagnosis of NF2, age of 12 years, a target NF2 related tumor that is growing over the past 36 months. We have some descriptions of what growth means, and individuals must have measurable disease because this is primarily assessed by MRI scans. We've built in a number of correlative studies that we hope to make available to researchers around in our broader community, looking a lot at blood and tumor biopsy samples for this genetic information, which can be very interesting, hoping to understand any correlations between genotype and response, as well as creating a library of imaging studies that can be used for advanced imaging, radiomics, and other ones as well. So that's a wonderful resource that we'll have. Each drug sub-study will be designed in a two-stage enrollment plan. In stage 1, 20 participants with any allowable tumor type is accrued to each basket, and we've mandated that at least 2 participants must have each type of tumor type because we don't want to miss this opportunity to identify any activity in tumor types that are not commonly treated, such as ependymoma. The interim analysis is performed after individuals have been on study drug for at least 3 to 6 months. If there are no responses of the target tumor at this stage, that sub-study will be terminated. And so that's why we're currently waiting to see our first 20 subjects if there's any evidence of response. If there is, we'll move to stage 2, accrue a second 20 participants, and in our adaptive design, we're only going to choose to treat those 2 baskets that have the highest activity. So if vestibular schwannoma and ependymoma seem to be the most responsive, we'll enroll to those 2 baskets in stage 2. As I mentioned, but can't show the data today, brigatinib is the first drug that has been nominated for inclusion in the Intuit NF2 trial. This is based on some outstanding preclinical work from the Schannomatosis effort that involved many investigators coordinated through the Children's Tumor Foundation. The drug is approved by the FDA for treatment of non-small cell lung cancer. And in this study, the primary endpoint, as I mentioned, is radiographic response. We have secondary endpoints here, which I described in detail before, and we have a lot of focus on tolerability and toxicity to make sure that the drug is tolerable. I want to transition now, and I guess let me just say one last thing about the Intuit NF2 trial. We're actively looking for new drugs to include in the trial, and you do not have to be involved in the trial group right now to bring a new drug into the study. So if there's anybody who would like to nominate drugs for the Intuit NF2 trial, please feel free to do so. We're happy to discuss about that possibility. I want to pivot now to schwannomatosis and to think about how this is distinct in some ways from NF2, and really to point out that whereas we focused on multiple tumor types and progressive tumors in the Intuit NF2 trial and the other trials, for schwannomatosis, our patients have identified chronic and debilitating pain as really being the most important symptom to treat at this point. We know that more than half of patients report a pain intensity score of at least 5 out of 10, which is moderate to severe pain. As we heard from Dr. Jordan earlier today, his work as well as others suggest that individuals with LZTR1 pathogenic variants appear to have more pain. That needs to be validated. We also know that surgery has limited benefit in this condition that can have generalized pain. And unfortunately, there's no class of pain medications that are clearly indicated for schwannomatosis. And really, until recently, there were no clinical trials that were up and running. And I want to mention here and build on the discussion by Dr. Sherman. His work, Dr. Ostrow's work, and others have really helped open this question of how do we design a trial. We have to think about what's the underlying biology. And so we know from their work, as well as the work of Dr. Lei Xu at Mass General Hospital, that cytokines, as well as other pain molecules, are important in this pain pathway. And many of these cytokines are overexpressed in these different models. So for example, here's a partial list of some of those cytokines that are overexpressed or upregulated, including nerve growth factors, CGRP, TRPA1, TRPV1, and interleukin-6. And you'll see that that's the same list roughly that Dr. Sherman talked about earlier today. So the trial I want to mention is a trial of tanezumab, which is a human monoclonal antibody that binds to and neutralizes nerve growth factor. It does so by binding to the TrkA and the P75 MTR receptors. And it leads to downregulation of some of these downstream pain molecules, such as CGRP, BDNF, and substance P. And you can see here in this cartoon, NGF here, which can be expressed through any kind of tissue injury, then binds to the neuron, the nerve endings, and elicits this cascade that we talked about, culminating, you can see here in the spinal cord. But I want to point out the other way to think about this is its effect on inflammatory mediators, which are common in tumors. And so NGF is also produced by a number of host immune cells. And so as I think about the effect of blocking NGF, it will involve both the immune microenvironment as well as the primary neurons. So the objective of this tanezumab study is to study the analgesic effect of the drug tanezumab given 10 milligrams versus placebo at day 57. If you want the details of this talk, Jennifer Dow will be speaking in a short while on this, and I hope that she can convey the details of this innovative design at that time. So in addition to looking at the analgesic efficacy, secondary objectives are to look at safety of tanezumab, and we have a number of exploratory objectives to look at pain over time. And I think that'll help us design better trials in schwannomatosis. Here's the design in schematic form. Again, Jennifer Dow will be speaking about this. Patients get screened. They either get treated with tanezumab for 8 weeks or placebo for 8 weeks, double blind, so nobody knows what they're being treated with. But ultimately, they also get the study drug for 8 weeks so that no person is treated with placebo only. And then there's a follow-up safety period to make sure that there are no safety complications. And that study will hope to have results in the coming year or so. I just want to finish on the next generation of clinical trials for schwannomatosis. Just to point out, we're moving forward with a similar design, that is with a perpetually enrolling platform trial, this time for schwannomatosis pain. It's a complement to the NF2, the Intuit NF2 trial. This will enroll patients with schwannomatosis who have moderate to severe pain. They will then be randomized to receive different drugs. We're starting off with an interleukin-6 inhibitor called siltuximab, building on the work mentioned previously. And then individuals can then rotate back into the master trial to be re-randomized to additional drugs. We hope that we can screen a number of different compounds over the coming years. I also want to mention the ongoing efforts by the EU PEARL team, the patient-centric clinical trials platform. This is probably the most exciting thing that's going on, looking at designing these platform trials more broadly across a number of different indications. And thanks to the work of Annette Bacher and CTF, that's going to include NF, many of the luminaries in our field, particularly across the pond, are working on this, and it's super exciting, and we're looking forward to seeing what platform trials emerge from the EU PEARL effort. And with that, I'll close by just acknowledging the very large group of individuals who have been working on various aspects of these studies. And if I forgot somebody, forgive me, I'll add your name afterwards, but it's an exciting time for NF2 and schwannomatosis. I very much enjoyed listening to the preclinical work so far in this meeting, and I hope much of that can be transitioned into the clinical trial realm in the next few years. Thank you very much.
Thank you, Scott, for your very good presentation. I have one remark. In fact, if I understand, only the surgeon can stop the perpetual platform trial. The surgeon only can stop your trial by removing the tumors. Yeah, it's okay?
By taking out the tumors.
Yeah, it's okay.
Yeah, sure.
I have a serious question. With your multiple trial for a tumor, how can change the biology of the tumor? You mean, you know, so I guess it will change a lot of compared to the baseline. So how can you manage this?
So, you know, that's a very relevant, it's such a great question. So if you treat with drug A, let's say in this case, brigatinib, and then a tumor shrinks and then progresses, what escape mechanisms, what genetic or other effects happen? The answer is we don't know. We haven't seen that much genetic alteration in tumors over time. They remain pretty genetically similar. In a perfect world, we would be getting biopsies, you know, at these points. We have not chosen to do so, either because we worry about the possibility of neurological dysfunction, and also many of our participants wouldn't do that. That is a blind spot. It is a great observation and one that I don't have an easy answer for. I think we'll see, you know, it depends how deep the response is before something comes up to know whether we think it's a real effect or not. And I think we're going to have to see. I don't have a great answer yet how we're going to manage that.
Justin, any question?
I think that's great. It's we're just a couple minutes over, so I think it's very reasonable to move on if that's okay.
Next speaker. Yeah, thank you,
Scott, very much.
Our next speaker is Rebecca Burns from NGH. She's counseling at genetic counseling at NGH, and she will talk about genetic testing to gain diagnosis clarity in NF2 and Schannomatosis. Thank you, Rebecca.
Good afternoon. My name is Rebecca Burns, and I'm excited to share this presentation on our project, which is titled Genetic Testing to Gain Diagnostic Clarity in Neurofibromatosis Type 2 and Schwannomatosis. NF2 and schwannomatosis are rare conditions that predispose individuals to developing schwannomas. This Venn diagram describes some of the key features of each condition, as well as highlights that there's an area of overlap in their clinical features. Because of this overlap in presentation, it can be difficult to determine if a given patient has NF2 versus schwannomatosis based purely on their clinical features. And despite the similarities between the two conditions, there are differences in the clinical management, including differences in the screening recommendations and treatment options. So even though patients might present similarly, it's important that they receive an accurate diagnosis to ensure that they're receiving the appropriate counseling and care. Genetic testing has become an important tool for achieving that accurate diagnosis, and it's even beginning to be incorporated into clinical diagnostic criteria. Testing can follow two different approaches, either a traditional germline-only testing approach or a paired analysis of both germline and tumor samples. It's believed this paired testing approach could be particularly beneficial within this patient population, given the high prevalence of mosaic NF2, which can account for up to 60% of cases. And often these mosaic cases of NF2 fall into this gray area where it's particularly difficult to distinguish between the two conditions. Although there's been an increase in the use of genetic testing for these conditions, the field lacked data that characterized an ideal testing strategy or really quantified the perceived benefit of paired testing over germline-only testing. So that drove the central question for our project: what factors are associated with gaining diagnostic clarity from genetic testing for patients with features of NF2 and schwannomatosis? Our main aim was to compare the efficacy of germline-only versus paired testing for gaining diagnostic clarity. And before moving forward, I want to provide a definition for this term of diagnostic clarity. For our purposes, it meant that further or future NF2 or schwannomatosis-related testing would be unlikely to reveal more information about the cause of a patient's clinical features. This could involve confirming a diagnosis by identifying a pathogenic variant, or refuting a diagnosis by ruling out the presence of a familial variant, or reducing clinician suspicion that a patient had an underlying predisposition syndrome. This was a retrospective chart review of patients seen by neurologists or neuro-oncologists and genetic counselors at the Massachusetts General Hospital NF clinic between 2015 and 2020. Patients met inclusion criteria if they presented with an apparent NF2 or schwannomatosis-associated tumor or had a family history of either condition, and they also had to complete genetic testing. Demographic, clinical, and genetic information were extracted from patient medical records and entered into a REDCap database. Then, logistic regression analysis was performed in our statistical software in order to identify any factors associated with gaining diagnostic clarity. This table summarizes the sample demographics. It's divided by the type of testing patients had, as well as summarized for the entire cohort. There were 76 total patients that met inclusion criteria, 43 of whom underwent germline-only testing, while the remaining 33 underwent paired testing. The sample was primarily composed of white patients, and there were slightly more women than men. The paired testing population also skewed slightly younger than the germline-only testing population. This is a similar table describing the sample clinical characteristics. Most of the patients in our study did not meet a clinical diagnostic criteria for either condition at the time of their genetic testing, although in those who did, NF2 was the more common clinical diagnosis. For these patients who already had a clinical diagnosis, genetic testing was a way to ensure that that diagnosis was accurate and also to enhance their level of diagnostic clarity through identification of a molecular cause of their features. Identification of molecular cause in turn enables cascade testing of family members, as well as pre-implantation genetic testing for patients considering their reproductive options. Most patients in our cohort had no known family history of either condition, and of those who completed paired testing, most only had one tumor sample analyzed, although 12 patients had 2 or more tumor samples analyzed in addition to their germline sample. This is the first in a series of charts that describes a proportion of patients that gain diagnostic clarity from genetic testing. In this case, looking at all patients in the study, we see that 37% gained clarity according to our definition. If we break this down by the type of testing they had, we see that only 26% of patients with germline-only testing gained clarity, compared with over 50% of patients who had paired testing. And our logistic regression analysis reveals that paired testing significantly increased the odds of gaining diagnostic clarity by a factor of just over 3. We can further delineate the sample based on the number of tumors tested and see that the greatest proportion of diagnostic clarity gained was in this population of patients that had 2 or more tumors tested. 67% of these patients gained clarity. And our analysis revealed that paired testing with 2 or more tumor samples significantly increased the odds of gaining diagnostic clarity by a factor of almost 6 when compared with germline-only testing. However, interestingly, there wasn't a significant difference in the odds of gaining diagnostic clarity between paired testing with 1 tumor tested and those patients who didn't have any tumor samples tested. This makes sense when we consider what's needed to confirm a mosaic diagnosis of either condition. If a pathogenic variant is identified in a single tumor sample, but can't be found within the germline sample, it remains unclear whether the variant is isolated to a sporadic tumor or constitutionally mosaic in the patient. To confirm the mosaic diagnosis, identification of the same pathogenic variant in a second anatomically distinct tumor sample is required. We also looked at the impact of age at the time of testing, as well as the presence of a clinical diagnosis, and neither significantly impacted the odds of gaining diagnostic clarity. So testing strategy and the number of tumors tested were the only significant factors. This table describes the results of patients who gained diagnostic clarity from genetic testing. I'll give everyone a few seconds to orient themselves to the information on the chart in the table. Here I wanted to highlight these 2 patients who received diagnoses that were neither NF2 nor schwannomatosis. These results illustrate the overall utility of genetic testing for achieving accurate diagnosis. I also wanted to mention these 4 patients whose results provided enough evidence that they likely didn't have one of these schwannoma predisposition syndromes. All 4 of these patients had paired testing, and this highlights the utility of paired testing over germline testing. Based on the pattern of mutations, or lack thereof, present in the tumor samples of these patients, clinicians were able to say that they no longer needed to follow these patients like they would someone who had one of these predisposition syndromes. This is a similar table that describes the results of patients who did not gain diagnostic clarity from genetic testing. Here I wanted to highlight these 10 patients who wound up with an unconfirmed diagnosis of mosaic NF2 or schwannomatosis. These are the patients I was mentioning before, who really require analysis of additional tumor samples to confirm constitutionally mosaic variants. And although they didn't meet our definition of diagnostic clarity, they may have still gained important information from testing. In fact, for 2 of these patients, the results of their tumor testing actually changed which of the 2 conditions their clinicians were suspicious of. So their clinical management was impacted by their genetic testing results. Overall, our study shows that paired testing provides significantly more diagnostic clarity than germline-only testing in individuals referred for evaluation of NF2 or schwannomatosis, and that this is further improved by testing on at least 2 tumor samples in addition to a germline sample. These results have important implications for genetic testing strategies and counseling patients. First and foremost, they support the routine use of genetic testing in individuals within this patient population, and they provide the basis for developing evidence-based guidelines for genetic testing. They also provide information that can guide patient and provider decision-making and cost-benefit analysis, and evidence clinicians can use to advocate for improved insurance coverage of paired testing for these patients. Paired testing does incur an additional cost and isn't always covered by insurance. Like all studies, ours has its limitations. First and foremost, there was variation in which genes were tested at what labs and the testing technology over the 5-year period of our study. Also, our sample isn't necessarily representative of the general NF2 or schwannomatosis population, especially given that our sample was predominantly white, and that we know there are cost barriers related to genetic testing. Future work in this area could look at offering updated testing for patients who previously underwent germline-only testing but have tumor samples available. We could also see how results changed or stay the same in a study with a larger sample size or funded research to address cost barriers. And finally, it would be interesting to explore the factors that influence patient decision-making about genetic testing within this population so that we could better understand how to counsel these patients. With that, I'd like to thank you for your time, and I'd welcome any questions.
Thank you. Professor Evans, do you want to comment or, yeah? Please.
Yes, very, very nice. I mean, obviously, we've done a lot of this type of testing, and there have been situations where we can refute an NF2 diagnosis in people meeting NF2 criteria. But I'd be interested in more granular detail on the 4 that you said do not have an underlying predisposition, because there are probably very rare examples of non-22q schwannoma predisposition. So it's, I think, quite a big ask to say, if you've tested 2 schwannomas and they just don't fit any of the current criteria, that it's definitely not schwannoma predisposition.
Yeah, I agree with that. I think I don't recall any patients who had 2 distinct schwannomas, and we were comfortable saying that they definitely didn't, or like we were pretty confident saying they didn't have one of these predisposition syndromes. For those patients, those 4 patients who their testing results indicated they were unlikely to have one of those predisposition syndromes, I think they typically had only 1 tumor present, and it was kind of a combination of their genetic testing results and their clinical features, their age, things like that, and we had discussions among the researchers about this.
It wasn't refuting, like our patient with bilateral vestibular schwannoma finding completely different genetic changes, not consistent with the same 22q copy. So it wasn't anything like that. Okay.
Correct, exactly.
Wonderful. Becky, that was a wonderful presentation. Thank you so much for coming today. I wonder if this should change the way that we approach our clinical care for patients who may not have a tumor yet, but maybe have one accessible. Does it make sense to begin somebody like that with germline testing only, or should we be doing more elective biopsies or tumor removals so that we can optimize our genetic testing?
Yeah, that's a great question. I think, and obviously it depends exactly on what the tumor is, where it is, how easy it would be to get a biopsy and things like that. And I think the data to me really show that there is a lot of utility, and even if you can just get one tumor sample, there is extra utility in that. So anytime it's possible to get that sample, I think it's worth it, you know, with consideration given to the burden of actually getting the sample. But I do think it's worth it. However, in a case where you can't get any tumor samples, I still think it's worth it to do the germline testing.
That's wonderful. I don't see any other questions on Slido, but feel free to send them along.
Justin, can I make one comment? This is Scott Botkin. Just to say that it's really important for those of us in the clinic to make sure that when surgeons like Dr. Kalimarides remove tumors, that they're saving them in a way that allows for genetic analysis down the line. So although our surgeons in our community do this routinely, many surgeons don't save the tumors in a way that allows for future genetic analysis. So it's a plea really to all the providers to make this available for our patients.
That's a great point, Scott. Sorry.
Yeah, there were a few patients in the study who had opted to have tumor analysis, and they did have tumors resected. But then when you go to find the tumor sample, it turns out that it's not able to be processed for genetic testing. So thank you for bringing that up.
And in fact, I would add to that that prospective discussion with surgeons is probably helpful, so that, you know, fresh tissue is still better than formalin fixed, paraffin embedded if possible.
Right.
Great. Thank you again, Becky. I don't see any other questions. So I'm going to move us on to our next speaker, who needs little introduction. Dr. Evans is a professor of genetic medicine at Manchester University, and is coming today to talk to us about assessment of multiple meningiomas as a major criterion for neurofibromatosis type 2 criteria. Dr. Evans, thank you very much for being here today.
Hello, I'm going to discuss with you today the usefulness of multiple meningioma as a criterion for the diagnosis of NF2 in the absence of bilateral vestibular schwannomas. So these are the so-called Manchester criteria, which we provided in our 1992 paper, which added to the existing National Institutes of Health criteria. The NIH criteria are in black here. And you can see here that in the absence of a family history, you have to have bilateral vestibular schwannomas. And we know that probably around 15 or even higher percentage of NF2 patients at initial presentation do not have bilateral vestibular schwannomas and may present with other tumors without vestibular schwannoma or even with a unilateral vestibular schwannoma and other features. So what we were able to add was the presence of a unilateral vestibular schwannoma and potentially multiple meningiomas as a criterion, as a major criterion, where if you had two other NF2 features, either two other tumors or two other features, including cataract, then you were able to make an NF2 diagnosis. And these criteria have stood up reasonably well over time. However, we've been aware, particularly since the identification of LZTR1, of a greater overlap between these criteria and schwannomatosis. So the main limitations of the Manchester criteria, one of these is in relation to those who just have bilateral vestibular schwannomas, that we were able to prove that an individual who had these or no other NF2 features actually had these tumors by chance. We calculated that possibly as many as 25% of people with bilateral vestibular schwannomas and no other features actually may have developed these by chance. The main concern, as I said, was the LZTR1. In our neurology paper, we found that 5 out of 34 individuals with unilateral vestibular schwannoma and 2 or more other schwannomas but no meningiomas actually had an underlying heterozygous LZTR1 mutation, and in those in several instances, we showed different NF2 hits in the tumors consistent with schwannomatosis. There was no overlap with SMART B1, and there was this issue of high-grade glioma not being a feature of NF2. So the neurology paper was where we really showed this overlap. And as you can see here, of those who did not go on to develop bilateral vestibular schwannoma, a significant proportion of those, nearly 15%, actually did not have NF2. So in that paper, and then following on in our Genetics in Medicine paper in 2019, we proposed some adjustments to the criteria. One was an age adjustment for bilateral vestibular schwannoma, and one was to make sure that LZTR1 testing was done in individuals with a unilateral vestibular schwannoma and 2 or more non-intradermal schwannomas, and that we, for the first time, put in a molecular testing criterion. So in that Genetics in Medicine paper, we were able to shed some light on some of the different categories that met criteria. And in particular, you can see here the concern over the UVS +2 schwannoma category, with a third of those meeting that criteria actually being refuted as having NF2, with 7 of those having an LZTR1 variant, and 1 actually being refuted on a tumor analysis. However, in the meningioma category with other features, no refutations were made, although we were not able to make a definite diagnosis in some individuals. In particular, we were able to show that in 137 individuals who had 2+ meningiomas and no bilateral vestibular schwannoma disease, that again, specificity in those with a proven diagnosis was 100%, although less than 50% we were able to make a definitive diagnosis. Importantly, going back, you can see here that unilateral vestibular schwannoma plus a sibling with NF2 category, that in all 3 of those cases, they did not have the NF2 genetic variant of their sibling. So a sibling diagnosis is not now included in the new criteria that you'll hear about in the that you've heard about in the meeting. So these are the new criteria, and as you can see here, that unilateral vestibular schwannoma and 2 or more meningiomas are still in the major criterion, but the first degree relative other than sibling is now in here to exclude that situation with a UVS with no affected parent. Looking at our current numbers, we have 1,620 patients meeting NF2 criterion, clinical criterion, or using the new molecular diagnosis. 131 met that criteria with a unilateral vestibular schwannoma and 2 or more meningiomas, compared to 96 meeting the criteria with the presence of other schwannomas as well as a unilateral VS but no meningiomas. And in our category, no cases were proven not to have NF2 based on a UVS and 2 or more meningiomas. This compared to 11% of those with unilateral vestibular schwannoma and other schwannomas. And again, here you've got the 7 LZTR1 plus now 4 that were discordant. So 11 out of that 96 who presented initially with UVS plus 2 other schwannomas. So highly significant difference in that specificity category. In our meningioma category, there was a marked female predominance in that 77% of this group with a unilateral VS and multiple meningiomas were female. This is highly significantly different to the 46% in the schwannoma-only group. In terms of molecular proof in this group, 37 were found to have a heterozygous variant in blood, and 27 were proven to have mosaicism based on blood analysis or 2 or more tumor analysis. This is a little lower than for the remainder of the UVS and schwannoma group, which was actually very high at 75%, but we did push the boat out a bit further in obtaining tumors in that group. A further 30 individuals met NF2 criteria with multiple meningiomas and no vestibular schwannoma. Again, there was a female predominance at 63%, high proportion with mosaicism, but 73% in this group we were able to prove that they had NF2, and again, no refuted cases. So when we look at the proportion where we can make a definitive diagnosis, you can see here that's much easier at younger ages when they're more likely to have their tumors removed rather than a watch and wait policy in the older people. You can see a high proportion of heterozygous mutations in those under 30, but the great majority being proven under 30. But once you get over 60, because again, it's rare to get more than one tumor out if they present over 60, you can see the majority are not proven, and that is just simply a matter of not being able to get access to tumor tissues. So overall, the conclusions of this are that multiple meningiomas are a very useful major criterion for NF2, and in fact, superior to unilateral vestibular schwannoma. This is particularly the case for women who are more likely to get more than one meningioma in their lifetime with mosaic or heterozygous NF2. And at present, we have no evidence for refuting someone with multiple meningiomas meeting clinical criteria as having NF2. And I'd like to thank in particular people in our lab, particularly Miriam Smith, Elka, and Andrew Wallace, and those on the NF2 schwannomatosis clinical group for the clinical criteria, in particular, obviously Scott Plotkin, who's been a major driving force behind this. And I hope that is useful. Thank you very much.
Great. Thank you so much for that wonderful presentation, Gareth. We do have one question from the audience, and I know that Dr. Calamaridis has one. I'm going to start with the question from the audience here. Do you recommend genetic testing in patients with 2 or more meningiomas and no other tumors?
So yeah, the pickup rate in that group is actually quite low unless they're very young. But we have undertaken analysis of multiple meningiomas in that group, and the majority do not have mosaic NF2. So we either find no NF2 changes in the tumors, so they're just not NF2 related meningiomas. So there's another cause, another genetic driver for their meningiomas, or that they don't have identical mutations. But there is a bunch that do have. So I would always do it if it's possible. If you have 2 meningiomas from a patient with multiple meningiomas, then it's worth doing the test to check whether they're mosaic. If you don't find it in blood, the risk of transmission is going to be extremely small. We very, very rarely in this group, unless they're very young, find anything in the blood if there are literally no schwannomas and no other NF features. But certainly a proportion of these do turn out to be mosaic NF2.
Great, thank you. And I know that Dr. Calamaridis has a question as well.
Thanks, Garrett, for your presentation. How can you explain the female predominance? Because we know from the sporadic meningioma, and in France, we have a lot of women with meningioma because of the progestin treatment, like ciproterol acetate. So in such population of sporadic or multiple meningiomas, we don't see any NF2 mutation. We see only mostly Pike 3A mutation. So do you have an explanation about the proportion of women with multiple meningioma, except hormone or progesterone?
So yeah, I mean, I just think it's simply that because of progesterone-driven nature of meningiomas, that women are more likely to get multiple tumors. If you actually look at meningiomas per se, then actually in NF2 and actually in SMART-B1, boys are more likely to have meningiomas than girls, and it reverses at around 16 or 17 years of age. And after that, the proportion reverses to being more female, and women are more likely to get multiple meningiomas than men get multiple meningiomas. So I think it's literally just that if you're mosaic as a man, you may get away without ever presenting with clinical features. If you're mosaic as a woman, particularly for truncating mutations, you're much more likely to get multiple meningiomas. And I think it's literally just that this is a very sensitive way of picking up mosaic NF2 in women. And, obviously these are people who met clinical criteria. So they had to have two other features. So that meant the meningiomas were highly unlikely to be driven by other drivers. They were much more likely to be driven by NF2 because they had other NF2 features.
Thank you, Gareth. We have a couple other questions from the audience. One individual wants to know, do you count optic nerve sheath tumors, meningiomas, in the meningioma count?
Yeah, absolutely. I mean, you'd have to be a little bit careful if you've got one at the chiasm that's sort of crossing over, that you don't count it twice. But absolutely, you'd count an optic meningioma as one of your meningiomas. And we do see, I have a few NF2 patients who've had bilateral optic nerve meningiomas, so it does happen.
And then I think along similar lines, another individual asked, how do you define multiple meningiomas? How about two meningiomas in the same posterior fossa?
I think if there's any evidence that there's a tail of meningioma between the two, they could just be the same initial underlying genetic change. You have to be a little bit careful. How you define the anatomical separation is difficult, but I would be very wary if you had two in the posterior fossa very close to each other, that they weren't actually all part of a single process, rather than really anything truly mosaic for NF2.
Perfect. Thank you again, Dr. Evans. We really appreciate the presentation today. Dr.
No problem. It's a pleasure. And always send your tumor.
Absolutely.
I've been banging on about it for years, but honestly, if you've got a sporadic patient, you need tumor in the majority of them to make a diagnosis. So absolutely. I mean, we've got actually brilliant FFPE testing now, but it's, fresh tumors even better.
Absolutely. Thank you.
Thank you. Our next speaker is Sheetal Fadnis. She's oncologist at the University of Alabama at Birmingham, and she will present the phase 2 study of axitinib in patients with NF2. It was difficult to get this talk in our session, so we have to fight, but thank you and with success. So we will listen to your exciting presentation.
Good afternoon. My name is Sheetal Fadnis and I'm a pediatric hematologist-oncologist at Children's of Alabama at UAB in Birmingham. I have no disclosures. I will be presenting the findings of a phase 2 study of axitinib in patients with NF2 and progressive vestibular schwannomas. This study was primarily conducted at the NYU Langone Medical Center in New York, which is where I did my neuro-oncology fellowship. As we know, a majority of NF2 patients are likely to develop progressive hearing loss by adolescence or young adulthood because of either unilateral or bilateral vestibular schwannomas. The treatment options for vestibular schwannomas are limited and mostly non-curative. Surgery and radiation therapy can leave these patients with significant morbidity, mortality, as well as decreased life expectancy. And the role of conventional chemotherapy in the treatment of vestibular schwannomas is limited and not validated. This brings us to axitinib, which is an oral multi-receptor tyrosine kinase inhibitor. It targets clinically or preclinically validated molecular targets in vestibular schwannoma, namely the vascular endothelial growth factor receptor or VEGFR, platelet-derived growth factor receptor, PDGFR, and c-KIT. Our primary objective for this study was to estimate the volumetric response rate to axitinib in patients with NF2-related vestibular schwannomas. We also had some secondary objectives, mainly to assess the toxicity of axitinib with daily dosing in NF2 patients, to examine the association of volumetric tumor analysis with clinical measures of response such as hearing and quality of life, and to assess response in non-vestibular schwannoma tumors such as other schwannomas and meningiomas. Key inclusion criteria were a confirmed diagnosis of NF2, age of 5 years or greater, at least one volumetrically measurable vestibular schwannoma of at least 1 cc, MRI evidence of progression over the preceding 18 months, or progressive hearing loss. Patients with a history of prior treatment with bevacizumab or other agents targeting VEGF or VEGFR were excluded. Radiation therapy to a study target tumor within 1 year prior to enrollment was an important exclusion criteria. This is a diagrammatic representation of the study schema. This was a single institution prospective open label 2-stage phase 2 study. After baseline MRI and audiogram to confirm disease progression, patients who met eligibility criteria were entered in the study. Axitinib was administered as twice daily dosing in 4-week cycles with a goal of 12 cycles. Response evaluation with MRI and audiogram was performed at every 12-week intervals. Patients with evidence of disease progression were taken off study, and patients who had stable disease or some response continued on the study to complete the 12 cycles. This table represents the statistical study design for our study. We used a 2-stage Simon design, and we can see here for stage 1, we required 9 patients and at least 1 response to deem the study inconclusive so as to proceed to stage 2. As we just saw, the study required 9 patients and 1 response, and so the study completed the first stage based on responses. The second stage was open but ultimately closed due to slow accrual prior to completion. Now coming to our results, all patients experienced some sort of drug-related toxicities. The most common adverse events were diarrhea, hematuria, and skin toxicity in the form of skin rashes, which were all limited to grade 2. Another common adverse event was hypertension, which was limited to grade 3. As far as our response rate, 12 patients were enrolled. Their ages were 14 to 56 years. 7 out of 12 patients completed 12 cycles. We had 2 imaging and 3 hearing responses. The imaging responses were observed at 9 months and 6 months into treatment. Interestingly, 1 patient had an imaging response on one side but tumor progression on the contralateral side. Our best volumetric response was a 53.9% decrease in tumor volume. This is imaging demonstrating our best tumor response. We can see here after 9 months of treatment, the tumor volume has decreased by more than half. In conclusion, we found that axitinib has modest anti-tumor activity in NF2 patients with vestibular schwannomas. It is more toxic and appears to be somewhat less effective compared to bevacizumab. Further clinical development of axitinib for this indication does not appear to be warranted. Our final data analysis, including all volumetric, hearing, toxicity, and quality of life data, is ongoing. I would like to thank the Children's Tumor Foundation and the 2021 NF Conference for allowing me the opportunity to present our work. I look forward to any questions. Thank you very much.
Thank you. Any question? Yes, Justin?
So, Chantal, thank you so much for that presentation. I thought it was really great. A couple of questions come to mind for me. I recognize that some of the analyses are ongoing, but you had such a wide range of ages, which I think is important to allow for pediatric patients in these NF2 studies. I do wonder if you looked at the correlation between age and or the genetic pathologic variant as it related to those who did and did not respond.
So that has actually not been examined. We don't have the genetic information, I believe, for all the patients. So we could go back and try to draw some correlation and have sort of a trend. But we don't have the information for all the patients.
Great, thank you. The other question that I had was, we heard earlier about the crizotinib study that's looking at, one question is short-term treatment and monitoring for sort of long-term benefit. We know that many people use bevacizumab in sort of treat a little while, off a little while. For a toxic drug, which it sounds like axitinib might be described as being such, I wonder if there's any consideration for for this drug or future, if there's ongoing evidence that maybe you get responses, if we should be thinking prospectively about intermittent dosing or short dosing and monitor for long-term response.
That is a good point, and it appears as hypertension was the most limiting and prominent adverse event, and in that case, it would be a little bit difficult to do the on and off, because putting them on and off, also antihypertensives, was something that we would have to sort of manage in the background. But it is definitely something to consider. We would need a larger sample size, I guess, to come to that conclusion about whether or not we can take this into consideration.
Great. It looks like somebody built on to the question I asked and said, what about even lower dose of axitinib to see if there's efficacy, perhaps trying to balance against toxicity?
So we had 5 dose levels, and we did have to go down depending on the CTCAE grading for the adverse events. And so I believe all the patients were optimized in terms of how much room we had to go down. If we can, structure the dosing to see if a lower dosing works is, again, probably, something we can revisit in the future.
Great. And then the last question we had from the audience was, any thoughts about using axitinib as a second drug in combination trials?
That's a good question. The only reservation would be how it would be tolerated, considering it has its own toxicity profile. And if you were to combine it with another targeted agent, which will come with its own toxicity profile, and there is a lot of overlap with these drugs, so there's going to be a couple of specific toxicities that get really exacerbated that may not, work clinically.
Yeah, always a concern. I don't see any other questions from the audience. Just like to say thank you very much again for this presentation. I think that the data is important, additive to our field. So really thank you for coming.
Thank you so much.
And I'm going to introduce the last speaker here. So Naomi Eskenazi is a wonderful student who's been working with the group at Massachusetts General Hospital. And she's going to talk to us today about the longitudinal evaluation of pain in schwannomatosis patients. So thank you very much for coming today, Ms. Eskenazi.
Hello, my name is Naomi Eskenazi, and I am a college student who has worked at Mass General Hospital for the past 2 years. I would like to thank the conference organizers for the opportunity to present this research on behalf of my colleagues in Boston and Manchester. Today, I will discuss the longitudinal evaluation of pain in schwannomatosis patients. I have no disclosures to report. Before we delve into the research study, it is crucial to note that schwannomatosis patients are prone to chronic pain. It is the most common symptom reported by patients and negatively impacts both physical and mental functions. A majority of patients will resort to surgery or medication, but most will not become pain-free using these forms of pain management. Thus, there is an unmet medical need for medication specific to schwannomatosis-related pain. To date, progress has been limited by the lack of prospective data on the natural history and impact of chronic pain on schwannomatosis patients. The first aim of this study is to collect and analyze prospective data on the following qualities of the pain experience. 1. Pain intensity, or the severity of someone's pain. 2. Pain interference, the impact that this pain has on a person's life. 3. Pain self-efficacy, which is one's confidence to achieve daily and life goals despite this pain. And 4. The impact of this pain on one's mental health. The second aim of this study is to inform clinical trial design for schwannomatosis-related pain. By collecting data on pain-related measures from schwannomatosis patients over time, we can better understand the point changes for each scale that can be expected in the course of natural history. This information will be critical to accurately design upcoming clinical trials. 79 adult patients were prospectively recruited from the International Schwannomatosis Registry. Participants were recruited by local PIs at MGH, New York University, Johns Hopkins, and University of Manchester. Enrollment began in November 2015 and is ongoing. Patients are sent online questionnaires every 6 months for up to 5 years. The questionnaire is split into 2 sections. The demographic section, which covers questions about age, race, gender, and familial inheritance of schwannomatosis. Patients are then asked about their pain medications, more specifically, whether they are taking any opiates, neuropathic pain medications, or NSAIDs. They are also asked about any previous or current schwannomatosis surgeries. The second half of the questionnaire covers the ranking of the following patient-reported outcomes: NRS 11, or pain intensity, ID pain, pain quality, PSCQ2, or pain self-efficacy, physical functioning, anxiety, depression, and then pain interference. Each of these outcomes are ranked on a scale as listed underneath in the total score row, where PROMIS forms are ranked on a 0 to 4 scale, but scored on a 0 to 100 scale with a mean of 50 and a standard deviation of 10. In the bottom row of the table, you can see what a higher score will translate to. For all the rankings except for PSCQ2 and physical functioning, a higher score means more of the outcome. To analyze the data collected from the questionnaires, we began by using the Health Measures Scoring Service to automatically generate T-scores for all of the PROMIS health measures. Using published thresholds in the literature, we defined a clinical meaningful change as follows: a change of 2 for the NRS 11 scale as recommended by Raines, and a change of 2 for the PSCQ2 measures. For PROMIS measures, we used a difference of 5. To assess the significance of a relationship between pain intensity and other pain-related outcome measures, we used a Pearson correlation coefficient. At baseline, 58% of the 79 patients were female and 16% had familial schwannomatosis. The median age was 51, with a range of 30 to 78 years. 11% of the participants were from the UK. 77% of patients reported use of pain medication at baseline. 47% were using neuropathic pain meds, 41% were using NSAIDs, and 33% were using opiates. These values don't add up to 100 because some patients were taking more than one type of medication to manage their pain. On the left is a table of PROs with the corresponding mean at baseline. As you can see, the mean for the NRS is 5, right at the middle of the possible range of scores. Pain self-efficacy and pain identity are both slightly higher than midpoint. The mean for pain identity is 2.3, suggesting that these schwannomatosis patients' reported symptoms are consistent with neuropathic and nociceptive pain. On the PROMIS scores, patients reported higher than average pain interference and anxiety, and slightly lower physical functioning and depression. The box plot graph here shows the pain intensity scores for the entire cohort at each time point. The corresponding number of patients who completed the questionnaire at each time point is marked at the top of the graph. The x-axis values represent each time point. On the y-axis is the pain intensity scores. As we can see from the red diamonds and the blue dashes, which represent the means and medians of each time point respectively, the group means and medians remain fairly consistent over time, staying between a score of 4 and 6. To represent the fluctuation of individual participants' pain scores, here is a graph that depicts the pain intensity scores for 2 illustrative patients over the length of the study. As you can see, there is significant fluctuation over time. The patient represented by the blue line has scores that range from 1 all the way to 10. Some patients, shown here for example, have much less fluctuation, and yet would still be considered as having a significant change in pain under the difference of 2 recommended by the Raines collaboration. This next graph shows the cumulative proportions of patients with increase in pain intensity scores at each time point, which allows us to observe any given change in score over time. The time points are still represented by the x-axis, and the percent of patients experiencing an increase is represented by the y-axis. The increase in score is represented by the corresponding color key. At 6 months, for example, 32% of patients had experienced pain worsening by 1 point, which then increased to 49% of patients at 12 months. Since a 1-point increase is something only participants with scores of a range 0 to 9 can have, the number of participants that were included in the calculated cumulative percentages decrease. The number of participants included for each curve is marked at the end of each corresponding line, and the possible range of scores the participants had to have is listed in the eligible score column on the right. So, of the 67 patients that were eligible for a 2-point increase, 55% had a significant worsening in pain by 54 months. A similar graph is shown below, but this time with the cumulative proportion of patients that had a decrease in pain intensity scores at each time point. When looking at the line that represents the difference between 2 points, or significant change, we can see that at the end of the 54 months, 54% of the patients have had a significant reduction in pain scores. This means that the remaining 46% have not had a significant improvement throughout the entire trial. This slide shows 2 sets of data that have to do with other schwannomatosis pain-related symptoms. The first shows the significance of associations between pain intensity and patient-reported outcomes. Pain intensity is positively correlated with pain interference, pain quality, and depression, so that the higher the pain intensity score is, the greater the outcomes will be. Pain intensity is negatively correlated with physical function and pain self-efficacy, so that the greater it is, the less function and confidence one has. These correlations were expected, considering that pain negatively impacts physical and mental life. The second data set shows a percentage of patients at 1 year that have worse, stable, and improved for some of the measured pain outcomes. As we can see from the quantity of green bar in comparison to the rest, a majority of patients had stable scores at 1 year. In conclusion, the prospective data confirms previous retrospective reports suggesting that pain severely affects mental and physical health in schwannomatosis patients. Despite the high and consistent use of pain medications among the participants in the study, pain intensity remains high. Over time, group averages for pain intensity scores remained relatively stable, while individual scores fluctuated significantly. We found that 34% of participants had a 2-point increase or worsening in pain intensity using the NRS-11 scale, while 36% had a decrease or improvement in pain intensity. This information is already being used in the first trial for schwannomatosis-related pain, which is currently underway. You can check this out at 3 p.m. today at Jennifer Dawes' presentation on a clinical trial of tanezumab for schwannomatosis-related pain. I'd like to thank everyone who made the study possible, including colleagues at Mass General and the University of Manchester. This study would not be possible without the support of the Children's Tumor Foundation. I especially want to thank all the participants who have answered questionnaires all of these years. And finally, a big thanks to Jennifer Daw, Vanessa Merker, and Dr. Plotkin for their mentorship.
That was wonderful. Thank you so much, Naomi, for that wonderful presentation. We don't have any questions yet through Slido, but Dr. Calamaris, do you have any questions to start?
Did you analyze, maybe it was not the goal of the study, but the role of surgery? Means we see patients with multiple surgeries, and do you think that it will affect all the score of pain? What do you think?
It's a great question. Yes, I think it does. We know that over 90% of patients did have surgery. We didn't analyze it in depth that much this time, but I know that the study is ongoing and that will probably be analyzed soon.
That's a great question. And certainly I think you might be alluding to a chicken and egg sort of question there as well, Michelle. Is the surgery a part of the pain or is it used to treat the pain? Which I think is a fascinating question. Naomi, I was interested to know, you talked a little bit about the fact that patients may have taken multiple drugs, but I wondered if you had any more evidence on, were patients in general taking 1 drug, 3 drugs, 4 drugs at median or average? Do you know?
I don't think so.
Okay. I think that will also be interesting. Certainly there are patients who come in taking multiple drugs at once. I don't see any other questions from the audience.
Maybe I have a question, but not on the last presentation. Maybe on NF2 trials. Maybe Scott, I don't know if Scott is around, or you, maybe Justin. In the phase 2 study on axitinib, patients with previous radiosurgery were excluded at least 1 year. Do you think that 1 year is sufficient? Because we know that sometimes you can observe growth during the first year or 2 years and then stop. So in the future trial, how do you manage a previous radiosurgery even in the platform trials?
It's a great question, Scott.
Because
would you like
we have to consider this because, you know, when you give advice for the treatment of a schwannoma to a patient, if the patient will get radiosurgery, it can be excluded maybe more than 1 year from trial. So why did you choose 1 year?
I'm here if you want, but I believe that the answer is we excluded for 3 years. I'm going to check it right now. I'm going to pull up the protocol. And I think this is just an area where we have to decide together, you know, to harmonize our inclusion criteria. So we do it the same way. So it's a great point. And, you know, Matthias has done, Dr. Karianis has done so many trials. You know, it's good for us all to kind of get together and see what works. So let me pull it up. But I think it's 3 years from our point of view.
Because in the axitinib, it was 1 year, no? What did you say at the beginning of in the phase 2 with axitinib? It was 1 year?
Yes, I said 1 year. It's 1 year.
Yeah, what you say, yeah. I think it's an important point to do this work.
Mm-hmm.
Yeah. While Scott's looking at that, we did just get a note from the audience. Schwannomatosis patients I have seen generally reported improvement in pain with surgeries until tumors grew back. So it's worth evaluating long term. I think that that's an important consideration, and certainly there are patients who I have referred for surgery. There is data from Vanessa Merker from probably 8 or 10 years ago that shows that pain relief is often temporary. Up to half of people may have their pain return even though they have pain relief from that surgery. But the audience member's point is a good one, that we don't understand fully whether that's tumor regrowth or whether that's pain recurrence, regardless of tumor presence or absence.
Michelle, it was 3 years for the Intuit trial for radiation, just to fill that in. But I think we want to recognize in schwannomatosis patients, there's both local pain related to tumors as well as more generalized pain. And one thing that we've learned is how complex the pain phenomenon is, the pain experience. In fact, in the new trial for tanezumab, Dr. Merker is now going to be performing soon, we hope, qualitative analysis of interviews to better understand what patients perceive rather than what we've assigned to it. And so we realize there's lots of nuance that remains to be kind of studied so that we can improve our outcome measures and really find the best way to help these individuals.
Absolutely. So again, Naomi, thank you so much for your presentation. I thought it was really superb and certainly will be helpful to future trial considerations. I don't see any other questions from the audience, so I'll take this opportunity to say thank you again to all of our speakers today. Really wonderful job, and thank you to all of you at home or work who tuned in. I think that this was a really wonderful presentation, and I'm sure that we would welcome any follow-up questions by email. Thank you and have a good afternoon. Bye.